Hello everyone, welcome back to this series of lectures in endocrinology. In today's session, we'll be learning about pituitary tumor syndromes. And we'll also be discussing about another very important pituitary tumor, which is your prolactinoma. So let's begin. So what are cellular masses? So we have learned that in our chapter on hypopituitarism that pituitary is basically located where? It is located in your cellar turcica on the sphenoid bone. So, tumors which basically arise from the brain, hypothalamus or pituitary is what we call as cellular masses. Okay, so any of the tumors which arise in your pituitary or in the hypothalamus are classified as cellular masses. Okay, so what is the importance of knowing these cellular masses? Because not every tumor that arises in the pituitary is a pituitary adenoma. That is the reason why we should be knowing about what are the different types of cellular masses that can appear and at what age groups that they appear. Because many of the times, like we had learned in our chapter on hypopituitarism, that lymphocytic hypophysitis in itself can mimic an adenoma, right? So we should be aware of what sort of tumors grow there and what sort of hormones they can produce and what sort of clinical manifestations they can have. Okay, so what are cellular masses? Cellular masses are those masses which arise either from the pituitary or from the hypothalamus or even from some of the brain structures. So let us look at the first group, which is your hypothalamic masses, because any mass in the hypothalamus can also cause hormonal disturbances if they produce any of those hormones. Okay, so if the anterior and preoptic nucleus is involved, if the anterior and preoptic nucleus of the hypothalamus is involved, what sort of symptoms will they have? They can have paradoxical vasoconstriction, tachycardia and hyperthermia. We know that the hypothalamus is involved not only with hormone secretion, it is involved in a lot of other functions including temperature regulation, it is involved in satiety, feeding, it is involved in your sleep-wake cycle, circadian rhythm, right? That is the reason why you should be knowing about each of the symptoms that can happen when different parts of the hypothalamus are involved. So, anterior and preoptic hypothalamus, when it is involved, there can be paradoxical vasoconstriction, there can be tachycardia, hyperthermia. They can present with central hyperthermia. If the ventromedial nucleus of the hypothalamus is involved, it can result in hyperphagia or obesity. These are syndromes that happen in early childhood, early onset hyperphagia, childhood obesity syndromes. So you have to think of hypothalamic masses as well. Then if the preoptic nuclei is involved, you can have polydipsia. Okay. Then the one tumor that you should be aware of in the hypothalamic region is something called as your hypothalamic hamartoma. So there can be hamartomas which can develop in the hypothalamus. There can be choriostomas. There can be ganglioneuromas. Okay. So one very important and relatively commoner tumor that arises in the hypothalamus is your hypothalamic hamartoma. Okay. There are two characteristic clinical features that you should remember about hypothalamic hamartoma. So the hormone that is produced here is your gonadotrophin releasing hormone. So the hormone which is excessively produced in your hypothalamic hamartoma is your gonadotrophin releasing hormone. Okay. So there is GnRH excess resulting in what? There is GnRH excess resulting in central precocious puberty. It results in central precocious puberty. Now, gonadotrophin releasing hormone is basically responsible for the production of FSH and LH. So, the FSH and LH are produced in excess and hence before the age of actual puberty itself, there can be early puberty which we call as precocity or precocious puberty. So, any precocious puberty that happens due to causes in the brain like your hypothalamic hamartoma is called as central precocious puberty. So, there can be central precocious puberty and there can be a type of seizures which happen during laughing. So, this is called as laughing seizures, and what is the other name for that? It is also called as gelastic seizures. Okay. So, in hypothalamic hamartoma, you can have GnRH excess which results in central precocious puberty and laughing seizures or gelastic seizures. And what is this Pallister-Hall syndrome? So, this hypothalamic hamartomas can be associated with craniofacial abnormalities. There can be craniofacial abnormalities or they can be imperforate anus. Okay, so Pallister Hall syndrome is basically hypothalamic hamartoma with craniofacial abnormalities and imperforate anus. So this is your Pallister Hall syndrome. Okay, so this is about the different types of hypothalamic masses. Now let us understand another pituitary tumor. So another pituitary tumor which is relatively common is your craniopharyngioma. Okay, this is your craniopharyngioma. So craniopharyngioma is basically a cystic tumor and it is a locally invasive tumor. So what are we discussing here? We are discussing about cellar masses. Now we have learnt about hypothalamic masses and we are learning about craniopharyngioma. So this is a cystic and a locally invasive tumor found where? In the cellar region, right? It is found in the cellar region. Okay. So what is this craniopharyngioma derived from? It is derived from your Rathke's pouch only. It is derived from your Rathke's pouch. So we know that the pituitary gland also develops from the Rathke's pouch. So a tumor arising from the Rathke's pouch which is cystic in nature and locally invasive which is found in the cellar region is your craniopharyngioma. Okay. And what is the age group in which this craniopharyngioma is very common? It is common in the age group of less than 20 years of age. It is common in age group less than 20 years of age. So how do you differentiate your craniopharyngioma from your pituitary adenoma? So that is where this becomes very important. It shows the presence of calcifications. Okay. So craniopharyngioma is like this. It is a cystic, it is a locally invasive tumor and it may show specks of calcification. That is how you differentiate from a pituitary adenoma. Pituitary adenoma on the imaging does not show calcification. It is not cystic. It is a solid and it appears hypodense. It appears hypodense on the MRI. So what are the symptoms with which craniopharyngioma can present? So in a young child with raised ICP with severe headache and projectile vomiting, there can be severe headache, projectile vomiting. Because of what? Because of mass effect. As the tumor increases in size, it can cause mass effect, it can cause raised intracranial hypertension. It can cause visual field defects because we know that where the pituitary gland is located, just above that you have the optic chiasm. You have the optic chiasm. Okay, you have the optic chiasm, and if a tumor grows here and compresses on this optic chiasm, then you can have visual field defects. Okay. Then there can be papal edema. There can be papal edema because whenever there is raised intracranial tension, you can have papal edema. So this can also compress on your or cause an obstruction to your CSF flow. So it causes an obstruction to your CSF flow and it can result in hydrocephalus. So in a younger individual less than 20 years of age with headache, with vomiting, with symptoms suggestive of hydrocephalus, visual field defects, the other pituitary tumor, if you find it on your imaging, you have to think of craniopharyngioma. Okay. So what is craniopharyngioma? It's basically a cystic locally invasive tumor with calcification that arises from the Rathke's pouch. What is the treatment? The treatment is predominantly surgery and radiotherapy. Without radiotherapy, up to 75% of the craniopharyngiomas can relapse. Okay. So the treatment is basically with surgery. You debulk the tumor and you subject them to radiotherapy. Now it has been found out that some of these craniopharyngiomas have BRAF positivity. So BRAF inhibitors like vemurafenib, darafenib, or even MEK inhibitors. So these are basically some of the proteins which have been found to be positive in craniopharyngiomas, and these drugs have been used in the treatment of craniopharyngioma as part of your trials. But the main treatment is surgery and radiotherapy. Okay, fine. So we have discussing about cellar masses, we have learnt about hypothalamic masses and craniopharyngioma. Now what are the other cellar masses that we should be aware of? One is chordoma. Okay, so chordoma, as the name suggests, is a bony tumor. So this is a bony tumor. So it arises from which bone? It arises from the sphenoid bone. Okay. So this chordoma is basically a bony tumor which arises from the sphenoid bone. This also shows the presence of calcifications. Okay. So how do you differentiate it from the pituitary adenoma? Here the normal pituitary tissue will be intact because it's arising from the bone. The normal pituitary tissue will be intact. In pituitary adenoma, you cannot find the normal pituitary tissue. Okay. Then you can have meningiomas as well. These meningiomas arise from the meninges. Okay. So this is about the various types of cellular masses. Now let us understand about your pituitary adenoma. So how do you classify pituitary adenoma? It is classified on the size, based on the size as macroadenoma and microadenoma. Right. So pituitary adenoma is benign or malignant? Adenoma is basically a benign tumor. Based on the size, it can be classified as macroadenoma and microadenoma. Macroadenoma basically means a size more than 10 mm. A size more than 10 mm is your macroadenoma and size less than 10 mm is your microadenoma. Okay. So based on what type of cells is the adenoma arising from, you can classify it into various other types of adenomas as well. Okay. So what we should be aware of is, one is this macroadenoma and microadenoma. Second is pituitary adenomas can have a property of secreting hormones, right? So they can be secretory or non-secretory. Secretory are the ones which basically are those which secrete hormones, and non-secretory pituitary adenomas are a small proportion but they do not secrete any hormones. Okay. Then based on the cell of origin, how do you classify them? So they can be classified as lactotropes, right? So they are all secretory adenomas only, right? So they can be classified as lactotropes if they secrete your prolactin. What is the hormone they secrete? Prolactin. So what are the symptoms with which a prolactin secreting adenoma or a prolactinoma presents with? It presents with galactorrhea. It presents with galactorrhea. It presents with infertility. There can be loss of libido. Okay. So galactorrhea, infertility, loss of libido is your lactotrope adenoma. Then gonadotrope adenoma, what will it produce? It will produce excess amount of FSH or LH. So what will it cause in females? It can cause ovarian hypostimulation or hypogonadism. Somatotrope adenoma. Somatotropes means what? There is excessive production of somatotropin or growth hormone. So this can result in acromegaly. This can result in acromegaly. Then corticotrope producing adenoma, what will it produce? It produces ACTH or your adrenocorticotropic hormone. So this can cause your Cushing's syndrome. It can cause Cushing's syndrome. Then acidophil stem cell, it produces both prolactin and growth hormone. Then you have your null cell and your oncocytoma. These are pituitary adenomas which do not produce any hormones. So null cell tumors and oncocytomas do not produce any hormones. Okay. Pituitary adenomas are basically tumors of the pituitary which are benign. They can be classified as macro and micro. Macroadenomas are those which are more than 10 mm or 1 centimeter in size. And depending upon the hormone secretion and where they arise from, they are classified into lactotrope, gonadotrope, somatotrope adenomas. And we have learned what is your null cell and oncocytomas which do not produce any hormones or they are non-secretory. Okay. Now let us also look at some of the genetic syndromes which are associated with pituitary adenomas. So what are the genetic syndromes which are associated with pituitary adenomas? So there are familial pituitary tumor syndromes. Most importantly, we have your MEN1. MEN1 is because of your menin gene mutation on chromosome number 11. So there is menin gene mutation on chromosome number 11. And what are the characteristic features? These include hyperparathyroidism. Remember all P's. Hyperparathyroidism. Then there can be pancreatic neuroendocrine tumors. So hyperparathyroidism, then we have pancreatic neuroendocrine tumors, then we have pituitary tumors, pituitary adenomas, and there can be adrenal adenomas and some carcinoids as well. Right? So this is your MEN1 syndrome. Then we have your MEN4 syndrome, which is due to a gene mutation in CDK and beta. There is hyperparathyroidism, pituitary adenomas, and a lot of other tumors, especially there are germ cell tumors. There can be germ cell tumors, gynecologic malignancy. Then you have another familial syndrome which is called as your Carney's complex. Carney's complex is basically comprising of pituitary adenoma with atrial myxomas, adrenal hyperplasia and lentigenes. Lentigenes are basically hyperpigmented macules which can be found on the face or in the oral mucosa. So apart from pituitary adenomas in Carney's complex, you have atrial myxomas and adrenal hyperplasia. Then familial pituitary adenomas can be seen associated with AIP gene which has acromegaly as well. Okay, so pituitary adenomas can be sporadic or genetic. The genetic syndromes associated with pituitary adenoma, you have to remember MEN1, MEN4, Carney's complex and familial AIP gene mutation. Okay, so this is about your genetic syndromes associated with pituitary adenomas. Now let us understand the features of cellar masses. So how do these cellar masses present? So first, if the pituitary is affected, right? So when the pituitary is affected, what happens is that this can result in, this is your pituitary and there is a mass. Now because of this mass, what happens is that the anterior pituitary can be damaged. Either the mass is arising from the pituitary or the mass is arising from maybe like a chordoma or meningioma, then this can cause compression of the pituitary. Pituitary can get compressed or there is complete damage to the pituitary, so the hormones can be lost. So all the hormones which are produced from your anterior pituitary can be lost, resulting in hypogonadism, hypothyroidism, growth failure, hypoadrenalism. Okay, so all of it can be lost. So this basically results in a panhypopituitarism. Then as it enlarges, as the mass continues to enlarge, what will it compress on? It can compress on the stalk and it can result in pituitary stalk effect. We had learnt about pituitary stalk effect in our chapter on basics. So let us just understand this again. So this is your pituitary. One molecule which is transported through the stalk. Stalk is basically the connection between your pituitary and the hypothalamus. So the molecule which is transported is dopamine. Dopamine basically has an inhibitory effect on prolactin. So when there is a pituitary mass which compresses on this dopamine is lost. The dopamine transport does not happen, right? So if the dopamine is lost, then the inhibitory effect on prolactin is not there. So the prolactin begins to rise. So there is hyperprolactinemia can happen because of pituitary stalk effect. Okay, so the hyperprolactinemia that happens because of pituitary stalk effect can also be a presenting feature of pituitary tumors. Okay, so pituitary tumors can have panhypopituitarism, they can have stalk effect. So now we will move on to the next manifestation, which is your damage to your optic chiasm. So the structure which is present in close proximity to your pituitary gland, just above the pituitary gland, is your optic chiasm, right? So if there is a damage to the optic chiasm because of the enlarging mass, enlarging pituitary mass, what will happen? You will get visual field defects. So what are the types of visual field defects which is expected? So let us understand that. So this is your right eye, this is your left eye. I am trying to explain the visual pathway again. This is your optic nerve which arises from both sides. They join together to form the optic chiasm, and then you have the optic tract. Okay, so this is your rough diagram. So right eye, left eye. Okay, it passes through the optic nerve, optic chiasm and the optic tract. Okay, so we know that the temporal field, the temporal area basically is seen or processed by your medial retina. Okay, so the temporal visual field here is processed by the medial portion. Now, how does this impulse travel? Now, the impulse, let us say from the right medial area or the right-sided nasal area, basically goes here, passes through the optic chiasm, decussates to the opposite side and moves this way. Similarly, from here, it goes this way. So, whenever you have an enlarging pituitary tumor, the enlarging pituitary tumor is going to be from here, right? It is going to be from below. So, this will start going upwards and start compressing on the optic chiasm, right? So, it goes upwards and start compressing on the optic chiasm. Now, once it starts compressing on the optic chiasm, then which part of the visual fields are going to get affected, right? So, which fibers? The nasal fibers of both the right and the left eye. It is the nasal fibers. Can you see here? It is the nasal fibers of both the right and left. So, if this gets affected, which fields are going to get affected? It is your temporal fields. It is your temporal fields. Okay, so I hope you've understood this. In the optic chiasm, it is the both nasal fibers which decussate to the opposite sides. So, what does it actually reflect? It reflects on these, it scans which area? It scans the temporal visual fields. Okay, so what kind of a visual defect will you have? You will have, this is a right eye, this is your left eye, so you will have bitemporal hemianopia. You will have bitemporal hemianopia. Okay, so you will have bitemporal hemianopia, you can have scotoma, blindness, loss of red perception depending on how large the mass is. Okay, so this is about your optic chiasm defects. Then hypothalamus. If the pituitary tumor enlarges to involve the hypothalamus, or if there is a cellar mass arising from the hypothalamus itself, then you can have temperature dysregulation, you can have appetite, thirst disorders, obesity, diabetes insipidus, sleep disorders, behavioral and autonomic dysfunction that we have just now discussed. Then, on the either sides of the pituitary, what do you find here? You find what? You find the cavernous sinus. You find the cavernous sinus. So, the pituitary tumor can enlarge sideways and it can involve the cavernous sinus. It can result in ophthalmoplegia, facial numbness, because what are the cranial nerve structures that basically are found in association with the cavernous sinus? You have your 3, 4, 6 cranial nerves, sometimes even your maxillary branch of your 5th cranial nerve. Okay, so you can have involvement of your 3, 4, 6 cranial nerve, your ophthalmic branch and your sometimes maxillary branch of your 5th cranial nerve. Right, that is the reason why you can have ophthalmoplegia, 3, 4, 6 are involved in eye movements, and you can have facial numbness as well. Then, sometimes, very rarely, the pituitary tumor can grow very rapidly larger, and it can even cause compression of the frontal lobe, resulting in personality disorders, anosmia, and sometimes it can result in dementia. And because of your compressive effects, you can have headache because of raised ICP, you can have hydrocephalus as well. Okay, so this is about the various clinical manifestations with which a growing pituitary tumor can present. Okay, so I hope that is clear. So we'll just recap. What have we learned? We are trying to understand what are all the clinical features with which pituitary tumors can present. So they can present with hypopituitarism. They can present with hypopituitarism. They can present with stalk effect resulting in hyperprolactinemia. We have understood why. We have understood what kind of visual defects. It is your bitemporal hemianopia. Then they can have hypothalamus disorders, cavernous sinus involvement, frontal lobe involvement. Now let us move on to the treatment. So the treatment basically involves your transsphenoidal surgery that we have already seen. So can you see here, this is just to give your perspective. This is your pituitary tumor, this is your pituitary. Can you see how it is compressing? It can compress the optic chiasm here. It can compress many of the nerves like your trochlear, trigeminal nerves in the sides. Okay, fine. Now what are the complications of your transsphenoidal surgery? So complications include a transient or a permanent diabetes insipidus. So whenever you are trying to remove the pituitary adenoma, you can cause damage to the posterior pituitary, and there can be deficiency of your AVP, which is your arginine vasopressin enzyme, and there can be diabetes insipidus. Same way, you can damage the surrounding cranial nerves, it can cause visual disturbances, and there is also a chance of CSF leak in 4% of the patients. The other way in which these pituitary tumors can be managed is your radiotherapy. But as we had discussed before, radiotherapy comes with its own complications of long-term hypopit. Okay, and radiotherapy can also cause optic nerve damage. Alright, so this is about your pituitary tumor syndromes. Now, just to give an idea about how these pituitary tumors appear. Okay, so can you see here, this is your mass in the pituitary. What will this be? It's hypodense. This is your pituitary microadenoma. Adenoma which is more than, let me use another color, an adenoma which is more than, let us see here, more than 1 centimeter in size is your macroadenoma. Can you see in image C that these are cystic lesions? So these are cystic lesions and they are showing the presence of calcifications. Cystic lesions in the cellar region with calcifications appearing hypodense. And can you see that the ventricles are also enlarged? So basically that means that it is causing some amount of obstruction and hydrocephalus. This is your craniopharyngioma. This is your craniopharyngioma. Okay, so that's how you differentiate between your adenoma and craniopharyngioma. Here can you see that only the pituitary stalk is thickened. Only the pituitary stalk is thickened. That is your hypophysitis. Okay. So with this, we have understood about cellar masses. We have understood about different types. How do pituitary adenomas present? How do different types of cellar masses present? What are the clinical features of pituitary tumors? Now let us move on to your next important pituitary tumor, which is your prolactinoma. Okay, so let us move on to prolactinoma. So before we move on to prolactinoma, we should understand, so what is hyperprolactinemia? So hyperprolactinemia basically refers to where you have prolactin levels which are elevated. Prolactin levels which are elevated in the absence of prolactinoma. So hyperprolactinemia means that the blood levels of prolactin are elevated, not necessarily the presence of a prolactin secreting pituitary tumor. So let us understand the etiologies of hyperprolactinemia. So physiologically, when will you have prolactin secretion? This we have learned, function of prolactin is for lactation. So in pregnancy and lactation, definitely you will have a physiological release of prolactin. Apart from that, chest wall stimulation during sleep and stress also, there can be increased levels of prolactin in the blood. Then hypothalamic pituitary stalk damage. So we have learnt about what? We have learnt about your pituitary stalk effect. We have learnt about your pituitary stalk effect. So we are basically looking at causes for pituitary stalk effect. So tumors like craniopharyngioma, meningioma, dysderminoma, metastasis, empty cellar syndrome, lymphocytic hypophysitis. Lymphocytic hypophysitis can also cause compression of the stalk and cause elevated levels of prolactin. Then similarly, adenoma with stalk compression, granulomas, trauma irradiation. Okay, so this is all because of stalk effect. These are all etiologies for your pituitary stalk. Then your third cause, the pituitary itself can cause release of prolactin. That is, a pituitary adenoma in itself or any pituitary tumor can start causing release of prolactin. So prolactinoma can cause release of prolactin. Acromegaly can also be associated with increased prolactin levels. So it's very, very important that you screen for all the hormones, all your anterior pituitary hormones whenever you are dealing with a prolactinoma, because acromegaly can also cause high prolactin levels. Okay, right? So this is the same thing. What are the three major etiologies that you have to consider as causes for hyperprolactinemia? One is physiological, second is what are the conditions which can cause pituitary stalk effect, and third is your adenoma secreting either a prolactin or even acromegaly can cause hyperprolactinemia. Okay, then what is this asymptomatic macroprolactinemia? This basically means that the prolactin levels in the blood are elevated. The prolactin levels in the blood are elevated, but there are no symptoms of prolactin elevation. That means that there is no galactorrhea, there is no infertility, but the prolactin levels are elevated. So why is that so? Sometimes the prolactin can be produced in the form of macroprolactin. Okay, so the peptide which is produced is of large numbers. So there can be macroprolactin. Okay, so it is like this, it is a large peptide. So when there is a large peptide that is produced, what happens? This is misinterpreted in the labs. This is misinterpreted in the labs as large molecules. Because of these large molecules, it is misinterpreted in the lab as hyperprolactinemia. So this is another situation that you should be aware of, which is asymptomatic macroprolactinemia. So you do a complete evaluation, you have not found any cause for elevated prolactin. It can be due to asymptomatic macroprolactinemia, where macroprolactin products are formed, which is misinterpreted by your system as elevated prolactin levels. Okay, so this is about your hyperprolactinemia. Now let us go on to what is this prolactinoma. So prolactinoma, as the name suggests, is the most common secretory tumor. Prolactinoma is basically a most common secretory tumor of what? It secretes prolactin. It is secreting prolactin. So this is a pituitary adenoma, most often due to pituitary origin. Pituitary adenoma which is secreting prolactin is your prolactinoma. Okay. So if the prolactin levels are more than 200 microgram per liter, then more or less you have clinched the diagnosis of prolactinoma, right? So more than 200 means it's more in favor of prolactinoma. But if it is like 50, 60, 100, then you have to think of other causes for your hyperprolactinemia, right? So if it is in a shorter range, then you have to think of other causes that we have just now discussed. So what is the triad of clinical features with which your prolactinoma presents? So the triad of clinical features is your amenorrhea. There is amenorrhea because prolactin basically causes suppression. It has a feedback inhibition of FSH and LH. So there is inhibition of FSH, inhibition of LH. So the menstrual cycle is stopped. This is a normal physiological action because during your lactation you do not need your menstrual cycle. So that is temporarily withheld. This is a normal physiological action of prolactin. So when there is excess secretion of prolactin, you can have amenorrhea. Then you have galactorrhea. Galactorrhea basically means excess milk secretion from the breast. And as a result of this inhibition of FSH and LH, you can have infertility. In males, what happens is that there can be loss of libido. In males, there can be loss of libido and there can be asthenozoospermia. So basically, the sperm production is also affected whenever there is a prolactinoma. In the long term, there is also risk of osteopenia and osteoporosis. Okay, so this is about the clinical features or what are the basic problems that happen whenever there is an elevated prolactin level. So how do you diagnose your prolactinemia? So diagnosis is by prolactin estimation. If the levels are more than 200, then this can be a definitive diagnosis of prolactinoma. Okay, but if the levels are slightly in the lower range, then you have to rule out the other causes for hyperprolactinemia before going and zeroing down as prolactinoma as the diagnosis. In the diagnosis of prolactinoma, there is another important effect that you should be aware of, which is your high dose hook effect. Okay, so what does this mean? So we know that how do you diagnose or how do you look for your serum prolactin levels? This is brought about by means of an antibody assay. Okay, so let us see that there are more prolactin molecules. These are your prolactin molecules. Okay, there are more prolactin molecules. So in your prolactinoma, there is elevated prolactin, right? So how are we diagnosing your prolactin levels? You are diagnosing using an antibody assay. Now the number of antibodies which are available are only so many. So the antigen-antibody complexes that are formed, are finally interpreted as your prolactin. Okay. So this much is only the value that you are going to get as your prolactin levels, right? But there are so many prolactin molecules which have not yet been bound. That means what? You will be falsely diagnosing or falsely missing out an elevated prolactin levels, right? So this is what we call as your hook effect. This is what we call as your high dose hook effect. This is called as your high dose hook effect. So what happens because of this hook effect is that there is excess prolactin. There is excess prolactin which is not being assayed because of this hook effect. There is excess prolactin which is not being assayed because of this hook effect, and this results in a false negative result. This results in a false negative result, and you might be missing out on your prolactinoma diagnosis. Okay, so always be aware of your high dose hook effect in the diagnosis of prolactinoma, because if there is excess prolactin levels, then sometimes you can miss it and there can be a false negative value because it is not being detected. Okay, so asymptomatic macroprolactinemia is different, this is different. So high dose hook effect can result in a false negative result. Okay, so for this, how do you prevent this? So in cases where you still have a high suspicion of your prolactinoma and you are finding that the prolactin levels are keeping on coming normal, they will come normal, right? It's false negative because some prolactin is not getting screened at all as a part of the diagnosis. So prolactin levels will continue to be normal. In such situations where there is a high clinical suspicion for your prolactinoma, then you check your prolactin in dilutions. You ask for diluted samples. So when you ask for diluted samples, then the assay becomes more sensitive. Okay, you ask for diluted samples to check your prolactin, and in diluted samples, the prolactin may come elevated. Okay, so this is about your prolactin estimation in the diagnosis of prolactinoma. The next would be your MRI brain. You have to do an MRI brain to visualize the extent of the tumor. You have to look for the visualization for the extent of damage, plan the surgery. Also, definitely you have to do a visual field testing to see how much damage it is happening. So if there is visual field involvement, then there is a definitive indication for surgery. Definitely you will have to go for a surgery if there is visual field impairment. Okay, now let us understand the treatment of prolactinoma. So what are the goals of treatment for prolactinoma? So you will have to do a shrinkage of the tumor. So the main goal is the shrinkage of the tumor size. Okay, so main goal is shrinkage of the tumor size, then relief of symptoms, and you have to definitely restore fertility. So these are the goals of treatment for prolactinoma. The first line management of your prolactinoma is use of dopamine agonists. What is the basic funda behind this? We have just now learned that dopamine is basically involved in inhibiting the prolactin. So you give dopamine agonist, then you inhibit the prolactin, right? So what are the two drugs? We have carborgolin and bromocriptine. So what are the two drugs? We have carborgolin and bromocriptine. Carborgolin is a long-acting D2 agonist which acts for around 14 days. Okay. Bromocriptine is an ergot alkaloid which is short acting. Okay. Which is short acting. What is the dose of carborgolin? It is given at 0.5 to 1 mg twice weekly because it's much more long acting. Okay. But bromocriptine is given at a 1.25 mg daily dose. Right? The response for carborgolin is much higher than bromocriptine at 80 to 90%. Okay? Because of its short acting nature, in the initial days, like recently there has been a change in your prolactinoma guidelines, but what has been suggested in your textbook is that because of its short acting nature, bromocriptine is preferred when pregnancy is desired, because it is short acting. No? When a lady with prolactinoma is planning for pregnancy, you can taper and stop the bromocriptine easily. Okay, because of its short acting nature. So in pregnancy, what happens is that dopamine agonists have teratogenic effects. So ideally, you will have to stop any dopamine agonist, be it carborgolin, be it bromocriptine. Okay, so because of its short acting nature, if a lady is planning for pregnancy, then we give bromocriptine so that it can be stopped easily. Okay, what are the side effects of dopamine agonist therapy? There can be constipation, there can be nasal stuffiness, nausea, vomiting, postural hypotension, and cardiac valve fibrosis is basically found to be another important association with your dopamine agonist therapy. Okay, in pregnancy, what is the important thing is that bromocriptine is used when you are planning. But the recent guidelines of Endocrine Society suggest that we prefer carborgolin because it is more efficacious. But bromocriptine can be easily stopped. Alright, so this is a slight controversial area, As per the textbooks and as per the old guidelines, it is bromocriptine. But now we prefer carbagoline in many of the centers because it's more efficacious. Now, a patient with prolactinoma has become pregnant. Then what do? You stop all dopamine agonists. Okay? And if there is no symptoms, then you continue your conservative management. Okay? You stop all treatment, you just watch for symptoms. Okay? What is the role of MRI? If a patient of prolactinoma becomes pregnant and starts developing visual field defects, that means what? That means that the patient's tumor is growing again. So that is when you will have to do an MRI. Okay? So this is about how you manage your dopamine agonistic therapy and how do you manage your prolactinoma in pregnancy. Okay? So if the patient has become pregnant, then you stop all your dopamine agonists and you wait and watch, monitor the patient for visual field defects. If she develops visual field defects, go ahead and do an MRI and plan for a procedure if it is very impending. Now let us understand the approach to your prolactinoma. So whenever there are elevated prolactin levels, always rule out your secondary causes, your causes for hyperprolactinemia. Then you look for MRI evidence of a pituitary mass. Okay? If this is a symptomatic prolactinoma, you see whether this is a macroadenoma or a microadenoma. If this is a macroadenoma, you would start with your dopamine agonist therapy. DA is your dopamine agonist therapy. Then you titrate your dopamine agonist therapy and try to maintain the serum prolactin levels less than 20. Okay, you try to target the serum prolactin levels to less than 20. If there is no improvement, you try to titrate. If one dopamine agonist is not working, you change the other dopamine agonist, try to increase the dose and you try to maintain the levels between 20 to 50. If it is continuing to be more than 50 and the patient continues to be symptomatic, or sometimes there might be patients who are planning for pregnancy, then you will have to consider surgery in these patients if there is no tumor shrinkage. Okay, so what you will do is you start with dopamine agonistic therapy, try to look for the prolactin improvement, try to look for the symptomatic improvement. If there is no improvement, you consider surgery. In the microadenomas, what happens is that you will have to, in your macroadenomas, you will have to, this is your micro, that is your macro. In macroadenomas, you have to do a visual field testing and never forget to test your pituitary reserve. Never forget to test your pituitary reserve because we have already discussed that whenever there is excessive prolactin secretion, there can be damage to the other anterior pituitary hormones as well. If the pituitary tumor grows in size, there can be damage to the other pituitary hormones as well. So you will have to look for all the other hormones as well. Okay, start with dopamine agonistic therapy. Repeat the MRI within 4 months. If there is no tumor shrinkage, you consider therapy. If tumor shrinkage is there, you monitor your prolactin levels and you do an annual MRI. Okay. So this is about how do you approach your prolactinoma. With this, we've come to the end of our session on discussion on pituitary tumors and discussion on prolactinoma. Thank you.